Yeah, good morning. So, as we are trying to find out what is when the right goes tends to go wrong in post-laser vision correction, the role of biomechanics cannot be considered to be just of a silent spectator, to be very, very honest. We have been knowing through these previous three talks that in excess of 4 million people globally undergo elective refractive surgery, out of which 0.04 to 0.06% patients go on to develop post-surgical ectasia. As Dr. Ritika rightly pointed out, more than 96% of the cases of ectasia belong to the category of patients who have undergone a LASIK, because LASIK gives rise to a weakening by 55 to 65% of the corneal elastic properties, whereas PRK leads to only 20% weakening. So what if we could find out in the nascent stage itself the reasons why this corneal lamellae are not able to hold the strength enough for these patients to move on with a normal life? So we all are aware that the ultrastructural changes precede the biochemical process and are responsible together for the biomechanical stability. And once this stability goes away, there is an alteration in the corneal shape, giving rise to optical aberrations and eventually leading to the poor vision quality, image quality, and finally a need for transplant. Unfortunately, the way the cornea is being diagnosed for the earliest cases of keratoconus is exactly the opposite. It first evolved from the slit lamp examination, moving on to topography, moving on to the corneal thickness and tomographic analysis. And now the unmet need of biomechanics is being evolving and being understood to its T. So the current standard of care, though, is involving only topography, tomography, and pachymetry, following up with an abnormal or normal differentiation, giving rise to a standard treatment. If the potential of biomechanics is completely met, we will be able to identify subclinical keratoconus and customize these tissues early with cross-linking and avoiding these patients from undergoing a keratorefractive procedure. So what is important for us here to know is how do we understand the biomechanics itself of the cornea? Since the most common instrument being used is the dynamic Scheimpflug tonometer or Corvus ST, we also understand the parameters. Also, by few examples, we'll know how to integrate this instrument into our daily clinical practice. The famous statement by Cynthia Roberts always will hold true. Cornea is not a piece of plastic. Cornea is a viscoelastic tissue. Elasticity meaning that it's the ability of the cornea to come back to its original shape on being deformed, and viscosity meaning the resistance that the cornea is offering to any deformation. And all of these are being provided by corneal tissue stroma itself, the ground substance being responsible for the viscosity and heterogeneity, and collagen fibers for the elasticity, along with the hydration response to the shear strain that the cornea tends to go through in and out through during the day. Thus, corneal shape is not only a geometric figure, it's not only corneal curvature, diameter, and thickness, but also an interplay of the intraocular pressure and the material stiffness which is coming from the fibrils, extracellular matrix, and the hydration. So if we understand how do we clinically apply this biomechanics, a focally reduced modulus of elasticity at any point in the corneal tissue will give rise to an increased curvature, redistribute the stress and strain, and give rise to further increase in the curvature, making it a vicious cycle. Thus, if we know about biomechanics, we'll be able to understand the biomechanical intraocular pressures. We'll be able to find out keratoconus very early. It will help us in our glaucoma managements also. And not only that, the response of corneal cross-linking and improved prediction of refractive outcome will be one of the major things that we'll be able to achieve. There are two devices which are currently commercially available to understand biomechanics in vivo. One is the Corvus ST, that is the corneal visualizing Scheimpflug tonometer, and the earlier one is the ocular response analyzer, which came to market in 2003. ORA was a non-contact tonometer, which through a pulse of 20 milliseconds, pulse pair of 20 milliseconds, which was being visualized through an IR emitter, and the rebound was being detected by a collimation detector, giving rise to first flattening peak 1 and a second flattening peak 2 or second applanation event. The difference between the two being called as the corneal hysteresis. And with the mathematical calculation, the corneal resistance factor was also being found. The hysteresis, resistance, pressure, and thickness that came about with the ORA was good enough for us for characterizing viscoelastic properties. However, not good enough for us for detecting the preclinical keratoconus cases. And it was found that the sensitivity and specificity of CH and CRF was only 78.9 and 63% in order to find out whether this patient could develop an ectasia post-surgery or even otherwise in life. Then came the newer solution in the form of Corvus ST. Corvus also has an air puff which goes onto the cornea. But the beauty of the instrument is it has a high-speed Scheimpflug camera, which is visualizing 4,000 frames per second through the 8mm diameter, unlike Aura, which is only for 3mm. And there are 140 images which are being captured over a 30 millisecond duration. It's already approved by FDA for density and for thickness, but in European markets and in India, it is being very well used for detection of early ectasias. The dynamic corneal response that occurs, that is the first applanation, is studied for its length, its velocity, and also the time that is taken to the formation. Also, there is a deformation which tends to occur. So the deformation amplitude, the radius, the peak distance of the epices, and the area under the curve or the radius of curvature is also understood here. Once the cornea tends to come back to its normal shape again, there is a second applanation event, which also gives rise to information regarding its length, thickness, and the velocity. So the machine is able to give us the dynamic corneal response parameters, an intraocular pressure parameter, and corneal thickness measurement at the same go. So we get three major reports by Corvus, which is DCR report, Vinciquerra screening report, and the Ambrosio-Roberts-Vinciquerra tomographic biomechanical assessment. You'll see one by one. But there's a new parameter from 2019, which is appearing to be very promising, and this is known as the stress strain index. So the dynamic corneal response studies not only the deformation amplitude and applanation length, it also inverses the concave ratio and gives us an integrated concave ratio. There is a availability of a dynamic video at the same time, which you can see, and a biomechanical corrected IOP can be obtained from the DCR report itself. The Vinciquerra screening report was basically a combination of the four parameters which were coming from the Scheimpflug tonometer itself. And in addition to that, the single frame picture of the horizontal profile of from center of the cornea to the periphery of the cornea, how the cornea is increasing in its thickness, gave rise to the Ambrosio relational thickness in the horizontal meridian. And these parameters combined gave rise to a very good index, which is known as the Corneal Corvus biomechanical index. The integration of the Oculus Pentacam and Oculus Corvus gave us a comprehensive report in the form of a CBI, a BAD-D, and TBI, as already mentioned by Dr. Raghav. The tomographic biomechanical combination can be a killer when it comes to diagnosing these cases and preventing the mistakes which we have been doing in the past. The latest stress strain index is developed by Ahmed El-Sheikh. Ahmed El-Sheikh is very well known for developing the biomechanical IOP, which is independent of the corneal thickness factor. The beauty of stress strain index is it's independent of the intraocular pressure, the corneal thickness. It has got basic correlation with age. So it's actually a measure of the material stiffness. The normal value of stress strain index is known to be approximately 1. And it is a very good parameter which can also help us in monitoring the pre and post laser vision correction changes and also what is going to happen once the patient undergoes a cross-linking. So as you can see here, the SSI index itself is able to tell us that whether the cornea is stiffer or it is softer or it is not significant. So there's a comparison map also available with that. So as per the review article published in 2019, the parameters of the Corvus ST, out of all the parameters, a cutoff value is 0.5 in CBI, and in TBI, it was found that the Ambrosio cutoff of 0.29 can give us a good indice wherein we can follow through with the patients. So I have just 4 examples. The first example being absolutely normal patient with a normal pattern, normal fraction. And you can see the Pentacam is absolutely normal. You can also notice the Corvus is normal, the TBI, the BAD-D, and the CBI are normal. So we can, in such case, proceed with surgery easily. In the second case, you can notice that the patient is having cylindrical error only in the left eye, and the corneal thickness is borderline, with the pentacam showing a borderline IHT. However, our CBI is also borderline. The TBI is going towards the red. It's crossing 0.3, 0.5 by a lot of amount. Even in the left eye, the TBI is showing to be 1. So now in such a case, we can't think of a surgery at all. We need to monitor this patient and consider this patient for a cross-linking in future if there's any increase. The third case shows a 6/6 part vision in the left eye. Again, the left eye is having a frank keratoconus with a thickness of 485. The right eye seemed normal. However, when we see the CBI here in this patient is around 1. So this is again a red flag. We are not supposed to touch this patient. So Vincigera et al. Had given up cases of 12 cases with BAD less than 1.6, but keratoconus on CBI. This is my final case. And again, the pentacam BAD here were abnormal. However, the TBI and CBI were absolutely normal. So here you can combine it with a cross-linking procedure. The refractive procedure can be performed with confidence. The extra confidence can come from the extra procedure.
With all due respect, sorry, Dr. Kiran, could you just please sum it up with next?
That's my last slide, ma'am.
Okay, no worries. Go ahead. Thank you.
So the hidden secrets of the cornea can be unveiled with biomechanical indices. However, in future, we are looking forward to supersonic shear wave imaging, surface wave elastometry, and Riva optical microscopy. Thank you for your time, and sorry for the delay.